Good morning, everyone. Welcome to Grand Rounds. It's my great pleasure this morning to introduce our speaker, Dr. Cheryl Anderson. Dr. Anderson is the founding dean of the University of California, San Diego, Herbert Wertheim School of Public Health and Human Longevity Science. Dr. Anderson serves as a professor in the Department of Family Medicine and Public Health and an adjunct professor in the Department of Medicine. She received her master's in public health from the University of North Carolina, Chapel Hill, and her master's of science and PhD from the University of Washington School of Public Health. Dr. Anderson's research focuses on nutrition and chronic disease prevention in underserved populations using observational epidemiologic study designs, randomized clinical trials, and implementation science. Her body of work addresses the effects of dietary patterns, sodium and potassium intake on blood pressure and cardiovascular diseases. She also studies behavioral interventions for adherence to dietary recommendations and identification of nutritional risk factors for the progression of kidney disease and the development of cardiovascular events in individuals with chronic kidney disease. Dr. Anderson is the director of the UCSD Center of Excellence in Health Promotion and Equity. She was a member of the 2015 U.S. Dietary Guidelines Advisory Committee and served on the National Academy of Medicine's Food and Nutrition Board. She is the chair of the American Heart Association's Epidemiology and Prevention Council and was elected to the National Academy of Medicine in 2016. Dr. Anderson will be speaking to us today on diet and disparities in chronic disease risk, examining the problems and accelerating solutions. Dr. Anderson, thank you so much.
Thank you, Dr. Jasal, and I appreciate that wonderful introduction. It's so nice to be with everyone today. I want to thank your other organizers as well as the co-hosts of this Zoom seminar for taking such good care of me and shepherding us all through this process. So it's my pleasure to be able to give this talk to you all today. As you just heard from the introduction, I have been having these types of conversations at policy tables across the country where groups of scientists from various institutions sit together to really think about what might be happening with regards to human health and the role that diet might be playing in that. However, in the words of Simon and Garfunkel, it's always nice to give a hometown concert. So glad to be here this morning. You heard a bit from my bio that I have had the opportunity to really sit in some pretty special scholarship circles. And when I was training, I trained in nutrition and I learned to do very tightly controlled nutrition intervention studies to address biological relationships between diet and health. At the same time, however, I knew that my career would have a public health focus. And in that setting, the goal is not to think about one person at a time, but really to think about hundreds or thousands or even millions of people at a time and how we impact population health. And what I was finding was that it was not straightforward to really integrate and synchronize the biologically based study data and what was going on when people left our efficacy or our effectiveness studies and were faced with real world challenges. So that's the basis of my talk today, is to talk a bit about what we're looking at from a disparities in chronic disease risk perspective, to talk about the relationship with diet, and then what happens after the studies in the ivory tower happen and people go back to face reality, and how we might think about that reality a little bit different from what we're doing as whether our job is to be a clinician or to be a researcher or to be a practice-oriented scholar. As you notice, the QR code is here if you want to get CME credit for the talk. So by the end of the lecture, I'd like for you to be able to do these 4 things. Summarize disparities in one measure of health status or in chronic disease mortality among racial ethnic groups. Describe the patterns in the healthy eating index that we see across the life course. use a public health framework to describe a complex interplay that's happening between biology, behavior, as well as social influences on diet and cardiovascular health. I use cardiovascular health as an example throughout the talk, even though the patterns very much so and the solutions very much so apply to other chronic diseases. With regards to chronic kidney disease, often the major cause of mortality will be cardiovascular disease before people experience end-stage renal disease. And explain to a colleague why, when we think about achieving health equity and eliminating those disparities that we see, we've got to have a focus beyond the clinic. So with regards to objective number one, from our national vital statistics system, we see disparities by place in this country. These are data on the left side of the screen for heart disease death rates by county, and stroke disease death rates are on the right by counties here in the US. And we see that both cardiovascular and cerebrovascular disease mortality varies. And this has persisted, and it's similar for other risk factors. So if we looked at obesity, high blood pressure, chronic kidney disease, even some markers of brain health, we would see very similar patterns across the counties. There are also differences by race, ethnicity, and how we experience mortality in this country. On the left side, we see life expectancy data, and in that, non-Hispanic Blacks in the US have persistently shorter life expectancy than whites and Hispanics. And on the right, higher burden of preventable cardiovascular disease death in non-Hispanic Black males and females than in non-Hispanic white males and females or overall. Age-adjusted total cardiovascular disease mortality rates from 2007 to 2017 by race ethnicity show a pretty grim picture for Blacks in the US as well. There has been improvement over the 2007 to 2017 time period, but as we can see, those increased age-adjusted death rates persist for Blacks. Now, mortality is, of course, a strong indicator of the health of a population, but there are other measures of health that can tell us about things other than death. For example, we want to know about life expectancy or years of potential life lost or disability-adjusted life years. On my screen, you see healthy life expectancy. These things are meaningful, and they tell us a bit about burden of disease. In the case of HAIL, that's the number of years that people are living in good health without any impairments from disease or disability. And again, we see marked demographic and regional variation in HAIL in the US. If we look at data from our morbidity and mortality weekly reports, we see that there are differences among those living to 65 years by where you live in this country, and also pronounce whether or not you're having an experience of a white person living in the country or a Black person living in the country. On the right, bottom right of the screen, you see globally how HAIL, when broken out by World Bank income group, differs if you're in low income groups versus higher income group countries. We also know that one of the best ways to impact health in a variety of domains is through diet. You could argue lifestyle more broadly. I focus on diet this morning, but you may be now very familiar with the Institute and Metrics for Health Evaluation Group at the University of Washington in Seattle, because they have been doing such amazing mathematical modeling for the COVID-19 pandemic. But across the decade, they have been working with the Global Burden of Disease study. And that has shown us that the top 10 causes of death and the relevant associated risk factors leave us in a place really forced to think about dietary risks, because that is the number one cause of death that's associated, the number one risk factor that's associated with the top 10 causes. More recently, a systematic analysis of dietary risks in 195 countries, this analysis was done in 2017 for the Global Burden of Disease study, revealed that poor diet quality has surpassed all other mortality risk factors, accounting for about 11 million deaths and approximately half of the cardiovascular disease deaths that we see globally. On the panel on the left side of my screen, You see age standardized mortality rates per 100,000 population, what's attributable to various dietary risk factors, and it's broken down by a sociodemographic index. We, on the right side, see the number of deaths at the global level attributable to diet. And hopefully, well, certainly no surprise to me, maybe not to you either, some of the key culprits are, salts, inadequate consumption of fruits and vegetables, whole grains, diets that are lower in omega-3 fatty acids and seafood, lower in fiber, and high in processed meats and dairy, high-fat dairy products. We also get data from the Global Burden of Disease study that is related to disability-adjusted life years. So again, thinking back to things that we care about that aren't necessarily death, because they tell us a bit more about burden. And we see similar patterns here and similar relationships of foods that we are concerned about for overconsumption as well as for underconsumption when it comes to good health. In the US, our surveillance system, the National Health and Nutrition Examination Survey, allows us to monitor what we eat in America. And you see here data that's estimated percentage of persons below, at, or above the recommendation for total fruit intake, for example. So the red bars on my screen represent in the top half of this graphic, males across various age groups. On the bottom half of the graphic, females across various age groups. And we see that in just about every sex age grouping, the intake is below recommendation for the majority of those in the grouping. When it comes to vegetables, the situation is even more bleak than we saw for fruits. A more holistic marker of dietary intake of those in America is the Healthy Eating Index. We use this as a way to assess adherence to routinely published every 5 years guidelines for Americans around diet. And the maximum total score that you can have on this index is 100. And here on the screen, you see what's happening in early life, so across childhood and adolescence. At ages 2 to 4, we see that the Healthy Eating Index is at around 60. That starts to decline into adolescence. And then throughout early adulthood, we see that score in the upper 50s, in middle adulthoods, near 60. And then it rebounds a little, but nowhere, near kind of what we would think about as optimal as we get older in ages 60 or beyond. So what's going on here? Are the dietary guidelines for Americans impossible? Are they merely aspirational? Let's take a quick look at them. So here are the guidelines for 2020 to 2025. We ask that we make every bite count, right? Here's how. Americans should follow a healthy dietary pattern, and the guidelines currently incorporate thinking about it at every life stage. In addition to following that pattern, really customize and enjoy nutrient-dense foods and beverages based on what's a preference. So your personal preference, culture, tradition, your budget. Also focus on meeting food group needs with nutrient-dense foods and beverages, staying within calorie limits, really thinking about not over-consuming in the general diet, and then limiting beverages that are higher in some of the things that we're always concerned about: sugars, saturated fat, sodium, and some limited alcoholic beverages. The importance of adhering to these dietary guidelines have been seen over and over in observational epidemiologic cohort study analyses. And those who are most adherent to the guidelines, they have a smaller waist circumference, they've got lower insulin resistance, reduced odds of carotid atherosclerosis, there's a slower progression of atherosclerosis, and there's lower total and overall cardiovascular disease mortality. When we think about what's happening locally here in San Diego, the Live Well San Diego data tells us that there's a concept that we can refer to called 3-4-50 for our region. There are 3 behaviors that we indulge in this region: not having enough physical activity, having poor diets, and the use of tobacco, that are responsible for 4 diseases cancers, heart diseases and stroke, type 2 diabetes and lung disease that are then responsible for more than 50% of the deaths that we see in San Diego. Now, these findings of observational epidemiologic analyses that I mentioned just a minute ago, they're really helpful, right, to help us get a sense of how we're doing in terms of diet and outcomes. And we've learned some things from some very well-funded efficacy studies of diet. So I'll give you an example of one from our lab here, where we were looking at what happens when we intervene on dietary salt intake with regards to dietary sodium excretion. The implications here are around controlling blood pressure and chronic kidney disease outcomes and cardiovascular disease outcomes. And this checkmark pattern that you see on the screen here is not that uncommon, right? Upon the completion of a very efficacious intervention, we get people from higher levels of mean sodium excretion down to the goal. But over time, and in this case, you see what happens over 20 weeks, those intervention efforts start to rebound a bit to where people were at baseline, even though in our case, we did see a marked difference between our control group and our intervention group. Another really well-known intervention project that takes into account lifestyle factors, diet included, is the Diabetes Prevention Project. And I give you these data as to illustrate, again, that checkmark pattern. In the red line here, you see what's happening with lifestyle intervention over time in the Diabetes Prevention Project. This one stretches out to about 48 months. That's and beyond that, we don't have the passive data collection or active data collection to know what's happening with regards to change in weight, but we see that things are on the rebound from where they were at 6 months. We can see it again in the Premier study funded by NHLBI. Again, change in weight happens from baseline to 6 months. 18 months later, we start to see that inching up. And then the weight loss maintenance trial did a lot better, but again, checkmark pattern exists, and we see it over and over. Look ahead study, etc. So, what's happening here? Why could this be problematic in terms of how we think about addressing diet and chronic diseases? Well, in my basic public health courses, I teach about the multi-causation disease model. And, to kind of sum things up, at the center of this model, you see that we come into this world with a genetic background, and that really matters for how we experience health outcomes. However, there are a lot of other contributing factors in this model, including the kind of environments that we in, what kind of healthcare system we have access to. Now more than ever, we see how important the backdrop for infections and disease outbreaks like SARS-CoV-2 and COVID-19 can be in how we experience health outcomes. And of course, the economics, as well as individual beliefs and behavioral choices. And so in some, right, our genes load the gun, but it's really the environment around us that ultimately pulls the trigger. So with regard to food environments, we know that's going to influence how people eat. So if you have the opportunity for fresh foods with a variety of choices that one might encounter in a grocery store setting, for example, the chances are, these things make it into the grocery store basket and then into the home and possibly into one's dietary intake. However, I used to work in Baltimore, and this is what I looked at outside of my office door when I would walk outside in terms of a place to get food. And when you roll up the doors to this facility and walk inside, these barriers are not the plexiglass barriers that we have instituted over the last 2 years to protect ourselves from infection. These are bulletproof glass windows, and the interaction here is to obtain your food, beyond that glass with, as you can see, the selections, sitting far away from individuals. A very different experience than you might have if you're walking into a grocery store setting. We've also made it really cheap and convenient to get a lot of calories and a lot of nutrients that we're concerned about. I took this photo outside of my window of my car, really just so surprised at the fact that you could get a massive, hamburger with lots of special things on it, adding salt, sugars, and fats, starting at $1. And really thinking through when I saw this, how, a family for whom economics are a concern, this might be an attractive and very convenient option. Furthermore, portion sizes are very different now than they were, 25 years ago. And you can walk out of many food establishments, whether it's for coffee or, a movie theater snack or, a burger, getting far more calories, salts, and sugars than one would have in earlier years. Furthermore, when it comes to something like salt, which I study quite a bit in my work, it's ubiquitous in the food supply. These data just really kind of blew me away. They are showing the mean sodium, mean calories, mean sodium per calories that you get when you looked at 11 fast food restaurants in New York. And importantly here is just to anchor you to what those numbers where you see the red circle on my screen actually represent. So the upper limit of what's recommended for sodium is 2,400 milligrams per day. And here you see people walking out of fast food restaurants with very close to the upper complete daily intake limit in 1,000 calories of food, right? And so if we think about someone having a 2,000 calorie diet and consuming more than one meal in fast food settings, this becomes a major problem in trying to address what people eat and ultimately health experiences that follow. Furthermore, we have made it very hard for people to stay aware of what they're consuming. So it's hard to know what's there. I use sodium as an example here because there have been so many efforts to counteract us making the information available to people. So I show you here a number of food items for which the amount of sodium in that one item exceeds the entire day's upper limit for sodium. And I couldn't believe it when I heard that the NRA and the CIA were kind of fighting New York State's health department about putting a notice on these items so that people would be aware. By NRA, I mean the National Restaurant Association, and by CIA, I'm talking about the Culinary Institute of America, to play on what happens in other politics around our country. But you can see here just how egregious some of these incidents are when it comes to just one single food. So in addition to, kind of struggling through the food environment, we know that there are other things happening more broadly on a societal context. And the Robert Wood Johnson Foundation Commission for Building a Healthier America started several years ago, really putting this into terms that make me, very sad and also keep me motivated to do this work. But what you see on my screen here are life expectancy information for various parts of New Orleans region in Louisiana. And in the Lakewood region, where people have routine access to great grocery stores, quality of life is relatively high. You see a life expectancy of 80 years. About 5 miles away in the Lafitte-Trem neighborhood in the French Quarter, where the experience of life is a bit different, the life expectancy drops to 55 years. So across 5 miles, a 25-year difference in life expectancy. That is just, for me, unacceptable. In our work, we've been trying to get a handle on how do we really scientifically think about the food environment and what can it tell us about, various risk factors and how people experience them. And I have to say, my experience in working on this with Laura Cobb, who was a PhD student with me a number of years ago, was a bit disheartening. So we started by trying to do this systematic review, and ultimately we noticed that the quality of the evidence was actually quite low. We saw predominantly null associations, and the need to really think about interpreting these cautiously because of the low quality of available studies. And so, as we all think about this as a community of scholars, we have a lot of work to do with regards to how we monitor and measure, as well as how we then draw conclusions about what's happening systematically in environments and these outcomes. So, this is medicine grand rounds, right? And I want to throw out a scenario for you that might help us kind of pull all of this together and thinking about multiple levels of challenges to achieving health goals. So let's say you have a 42-year-old mom of three, has obesity, uncontrolled diabetes, and hypertension. You want this clinic visit to focus on lifestyle modification, amongst the other things that need to get managed. Mom's motivated to make changes. However, if you probe a bit, you discover, and it's important to probe because your credibility, I think, really hinges on knowing a bit more about what this patient is experiencing. When you look at, zip code neighborhood, there's a lack of nearby stores with healthy food options. There's limited income for groceries because of lower wages. There's moms working a full-time job and a part-time job, doesn't really have a lot of time to prepare fresh foods as we might give in our recommendations. The neighborhood has limited opportunities for exercise, particularly at night, may not be somewhere that you want to be outside. There's some persistent uncertainty regarding other factors, things like electricity and utilities, limited support for self-care because there's, there are other vulnerable individuals at home who are being cared for. And overall, you see just this high level of psychosocial stress related to these things and to other factors. So what does this all mean? Like, what do you do with all of these challenges? Well, in public health, we rely on a socio-ecological framework that really helps us think about how do we incorporate things beyond the individual level into our thinking about improving health. And we think about this on a population scale, but I think there are some implications here for what happens in the clinic and beyond. So on the screen right now, you see a socio-ecological framework for cardiovascular disease risk and cardiovascular health promotion. And we see in the very bottom center that, yes, what matters at the individual level regarding to age, sex, and other demographics, race, ethnicity is really important. However, the behavioral setting, where do individuals live, learn, work, play, and pray also matters. There's sectors of influence, right? How are those places governed? What's the public health infrastructure? What's the healthcare system like in those communities? What are the various industries doing with regards to food and other lifestyle and environmental factors? And then what are the social norms and values happening? And so hopefully, this starts to really solidify this concept that lifestyle related risk factors, they cannot simply be viewed as simple behavioral choices. About 3 years ago, a team of us authored this scientific statement. Mercedes Carnathon, who's at Northwestern, led this effort. And we were trying to better understand cardiovascular health in African Americans. And we took a look at, the higher prevalence of traditional cardiovascular risk factors, hypertension, diabetes, obesity, atherosclerotic cardiovascular risk, and the relatively earlier age of onset of these conditions in African Americans, and the notable direct contribution to stroke outcomes, heart failure outcomes, PhD outcomes in African Americans. And despite available pharmacotherapy and some even tailored pharmacotherapy, disease management was often less effective. And we concluded that the strategies that were needed to promote equity in cardiovascular health in African Americans required a broader set of stakeholders and really a wider amount of thinking from different disciplines and different types of researchers and clinicians. Well, if you fast forward to what's been happening more recently, particularly during the pandemic and during this time in our history where there's a real social call to think about structural and systemic issues, racism being one of them, that might be fundamentally impacting how we see chronic health disparities. In this presidential advisory to the American Heart Association, we see structural racism being examined as a potential driver of what's going on in terms of these differences in health outcomes. And this was the first time that I'd seen in such a prominent clinical journal like Circulation, the figure that I'm about to show you next. So this figure links anti-Black structural racism and poor health. And so as we talk about challenges to diet and cardiovascular health and how to move forward with potential solutions, I think this figure gives us some key things to underpin what we might do next. So it goes all the way back to thinking about times of slavery, structures of racism that maintain white supremacy, thinking about even post-emancipation, what's been happening to maintain white privilege. And we see issues around segregation, redlining, the targeting of Black people and other biases within our racial justice system, and how those things are upstream factors from what then happens with regards to poor access to healthcare and the physical environment and other conditions around us that lead to increased, whether it's heart disease and cerebrovascular disease risk, or toxic stress, increased burden of the highest outcome, the highest health outcome in terms of contributing to deaths in our country and across our world, and then overall worse outcomes. Recently, just I think maybe 2 or 3 days ago, I saw a publication from the multi-ethnic study of atherosclerosis cohort, MESA cohort, where Mahasan Mujahid and colleagues look at redlining and its impact on health disparities, showing that higher exposure to redlining leads to worse outcomes. So these upstream social factors are really impactful when we think about chronic disease prevention and health promotion. And in this infographic, we see the relative contributions of various domains of factors. Of course, clinical care matters, right? We're talking about this at medicine grand rounds. We want people to have access to great and high quality care. The kinds of behaviors that individuals engage in also matter, and the physical environment around them, as well as the social and economic environment, however, is half the battle. And we really cannot escape thinking about these fundamental causes of health inequity and really starting to examine structure and systemic issues. So when we come back to the scenario with the mom who's in clinic, who's motivated to make changes, however, experiencing these various other factors, I think if we're going to try to achieve health equity, we're going to have a multidisciplinary focus that extends beyond the clinic. And so let me go into this very last section of the talk before we open up for Q&A, because this is much easier said than done. What do we do and how do we do it? So let's start first with maybe thinking a little bit about the what. And I have been in my sort of recent time thinking a little bit about, with some colleagues around the country, what we call Life's Simple 7, which is a metric used in the cardiovascular epidemiology community to think about underlying factors, diet being one of them, that if we could get a focus and an achievement of certain goals on those factors, we could accomplish better cardiovascular health. And it's time to really re-examine those simple, not so simple 7 factors and think about what to do next. And so if we're going to think about achieving cardiovascular health equity, I think we have to really start to ensure for everyone, of course, access to good care, quality preventive care for metabolic risk factors, as I've hopefully convinced you already in this talk, access to healthy foods. And it's not just about getting it periodically. There has to be security around it. There shouldn't be periods of time where people aren't sure that they're going to be able to eat well. Providing structural environments that support exercise and healthy activities, having stable and adequate residence and employment, thinking about quality childcare and education and the interpersonal and psychosocial support that goes along with that. So in the clinic setting, we really need providers who understand and think about the complex interplay that's happening between biology, behavior, and social factors, so that we can call to bear upon those interactions the resources needed to address these goals. So this schematic that you see here on my screen is a recent work in progress with this group of us who are thinking about the Simple Seven and what might be next with regards to those factors. And in addition to diet and lifestyle considerations, and by lifestyle, not having people smoke or exercising well, getting proper sleep, really thinking about monitoring and tracking across these various health factors, we know that there's a foundation on which some of these things are going to stand. So the general socioeconomic, cultural, and environmental conditions, as well as how people live and work, their social and community networks, then their individual sort of genetic and lifestyle risk. And then going beyond those social factors to also think about psychological health, right? Well-being, mindfulness, gratitude, optimism, purpose in life, to counteract some of the things that lead to chronic stress and lack of well-being in our populations. For me, I also think a bit about innovation in the food system. So I, have been really trying to think through since my time serving on the Dietary Guidelines Advisory Committee, which was is 2 cycles ago, 10 years ago. How do we make sustainability an everyday word when we think about foods and what foods might mean for overall health outcomes? Some of you may have come to the grand rounds that I gave about that topic, but at the time, the dietary guidelines could not even get published because we had dared to talk about a sustainable food system. And the advocacy against this in Washington led to some pretty intense debates and almost a constraint against the Farm Bill, which is linked to so many things in this country, where the Farm Bill wouldn't get approved by Congress because the dietary guidelines dared to say we should think about a sustainable diet. If you fast forward, however, from 2015 to 2019, sustainability started to be more popular in our conversations. We started seeing food advertisements on television about, we care about the sustainability of our products. And in my mind, in order for us to really get to a healthy, sustainable food system, we have to be thinking about food industry. We have to call our public health and medical colleagues to the table. We need to be thinking about what's happening in community settings, in school settings, what people are experiencing in their family environments, how the agricultural industry gets incorporated into this conversation, and then of course, policies that are being written globally, federally, and locally as well. And if you go back to the socio-ecological perspective that I presented minutes ago, when it comes to diet and chronic disease management, I think this could also be a part of our solution, really thinking through how the challenges for excessive intake of things that we're concerned about for overconsumption, and then limited intake of the things that we're concerned about for underconsumption could be impacted at the individual level. We can't do it without people sort of helping to participate in changing behaviors, monitoring their intake, asking and creating demand for what is going to be needed to promote good health. However, we see these concentric circles around them that I think are worthy of some conversation too. So if we shift over into the relationship space, right, we've come to these agreements in the clinical setting or in other counseling opportunities, whether it's with dietitians or health coaches. And we find that people are unable to achieve the goals that they agree upon in these settings because of challenges at home. So whether it's, with regards to home cooking or trying to, share meals, but having divergent goals from other people within the home. And then also thinking about who's in the home across the lifespan, children eating differently from, young adults, eating differently from older adults, and really needing to think about the entire family when interventions are done. And then, as I mentioned before, across the various communities that people are in, how do we think about strategically using procurement options? So for example, for years, I chaired the Jogathon, a fundraising activity at my son's school. And when I took over the Jogathon, one of the big special events with Jogathon was whatever classroom had the highest group participation rate, they ran the most laps at the Jogathon, would get this amazing pizza social. And I thought, when I took it over, is that really, the best that we can do here with our with the messaging that we do around, Jogathon and inherently relatively healthy activity that we then cap off with, a pretty salty, sugary, fatty experience. And I thought, well, let's see what happens if those dollars get used in a different way. Would there be a revolt? And actually got pretty good acceptance. I went to Rock and Jump, asked them to provide some support for the activity. I gave out, gift cards to Rock and Jump for the classroom that did it the best. And turns out that that has been sustained over time. And so, really thinking creatively about how we operationalize our dollars in schools, workplaces, healthcare settings, and in our recreational activities. And then with regards to societal factors, we need to build advocacy, whether it's through our professional societies or our local agencies and nonprofits to change laws, policies, the dissemination and implementation of the science that we do, so that healthy choices become more default choices, and really thinking about addressing structural issues such as racism and other factors that impact social determinants of health. Now, I think another piece of this conversation when we think about solutions, as I wrap up, is how do we manage across critical time windows in the life course? And if we think about this from a cardiovascular health perspective, and I want to credit Garima Sharma with this beautiful schematic in the work that we're doing right now and thinking about Life Simple 7 and other factors in cardiovascular health. In pregnancy and in utero and in infancy, we've got responsibilities, right, related to OB visits, well baby visits, in early childhood, establishing physical and mental and cognitive habits and changes that are going to be foundational for what people will pull forward. And we do this through public health efforts, neighborhood programs, as well as the clinical setting. In early, well, actually, you could argue that we could have in here adolescence as well, a time of transition of care, going from, seeing a pediatrician maybe into seeing an internist. In early adulthood, focusing on not establishing those risk factors in the first place. So more of a primordial prevention rather than, waiting for risk factors to develop. And then through early screening, thinking about mitigating those risk factors. Also, really thinking about well visits in primary care settings. In middle age, optimizing risk factor control, making sure that people are on optimal medical therapy if they need it, and that lifestyle modification in secondary prevention is evident and supported. And then in older adulthood, avoiding frailty, thinking about reduction of comorbidities and chronic diseases, and then, as we see so importantly right now, up-to-date vaccinations. So I've thrown a lot out in terms of challenges. Hopefully, enough around potential solutions that we can have a high quality conversation. And I just want to wrap up by saying, in this conversation, we, I think, have evolved over the last decade or so in thinking about, with regards to health, it's not just about equality in health, it's more about equity in health. And this graphic is one of my favorites because it just so beautifully illustrates what it is that we're trying to shoot for. So if you look at everyone in this graphic, three individuals of different height trying to get access to a soccer match, in the assumption that everyone's going to benefit from the same support or giving them equal treatment, you give them all the same box and you see that it doesn't quite solve the problem. However, when you think it through an equity lens, and if we think about this through a health equity lens, you give people the support they need, right? So one person needs 2 boxes, one doesn't need a box at all, and the other needs just 1 box. But I think, now we're at a place where we really want to think about justice in health. And the real shift, I think, is to remove the source of the inequity. So here, when you get rid of that fence, that's really the blocking structure between everyone being able to see the fence, and remove that systemic barrier, then you don't even need to make the accommodations with the box at all. So with that said, I want to thank you for the opportunity to share these thoughts with you today and a bit of my work, as well as some of the things I've been doing with regards to policy. Here is the QR code again that you can use if you'd like to claim CME credit for this course. I will stop sharing my screen so that we can open up for Q&A.
Dr. Anderson, thank you so much for that compelling presentation. Very, very lovely. We have a question. Thank you, Dr. Anderson, for raising awareness of health disparities. Can you discuss briefly the role of micronutrient supplementation as a cost-efficient way of preventing morbidity and mortality in areas of extreme poverty around the globe? For example, vitamin A supplementation to prevent blindness.
Yeah, thank you for this question, because what I didn't go into in depth in this talk are the cases where we have real need to think beyond foods and food groups and dietary patterns and start to think about supplementation. And dietary supplements are necessary in certain contexts. They are a popular approach that's taken in other contexts where I might argue that they're not as necessary. And to get to the heart of this question, when we are in environments where deficiency is clear. So one of the scenarios that the person was asking the question talked about was, vitamin A in the case of blindness, or vitamin D in the case of rickets, or other overt expression of diseases that can be clearly linked to deficiency states. Supplementation is absolutely critical and should be employed. That said, we have to counter the public health approach in scenarios or contexts where we're not in deficiency states, where actually you could argue that we're in a context of overconsumption, and we find that populations may want a magic bullet of sorts. Like, what is that nutritional factor? What is that supplement that is going to undo years and years of overconsumption of things that we're concerned about, such that you can experience better health? And there is none, right? We've seen it time and time again through epidemiological cohort analyses around vitamin E, for example, beta carotene, for example. And in the cases of adequacy, those nutrients can actually sometimes lead to increased mortality and poorer outcomes. So thank you for the opportunity to really balance that. Across this globe, for certain, there are places where deficiency exists and vitamin supplements are absolutely critical.
Thank you, Dr. Anderson. Another question: without critically affecting fast food utilization of salt, it would appear that almost everything else done is just treading water. Is a more aggressive approach needed?
Yeah, so absolutely. There are a lot of subtleties in the question that was just asked. So appear to be treading water, yes. And a part of the counterbalancing forces here are things like things like advocacy groups, right? So we have advocacy groups that are helping us advance the public health approach. And then you have advocacy groups that are working against the public health approach. So let's take the case of salt. For example, where for a very long time, there was something called the Salt Institute. And the Salt Institute would engage very prominent scientists who would argue quite persuasively that excessive salt is merely excreted through the urine, and there was no impact on human health. And then you'd have scientists on the other side of this argument, prominent as well, saying, no, there's a pretty direct progressive relationship between salt and blood pressure. And when you intervene on salt, you see blood pressure reductions that have concomitant benefits for heart disease, kidney disease, and other outcomes. And so the platforms that, the public health agencies and the pro nutrient or pro sort of food group units use were at quite attention. So now, in terms of what do we do next, I think we try with data to continue to show the extent of these issues, and we start to take a different approach to those data. So you saw me show what we see in our observational cohort studies, and really how there's a disconnect between the public health framework, where we have to think beyond those variables that are in the analysis that are often collected, in a clinical setting, to these broader things. And I think bringing a number of different disciplines to the research team, bringing a number of different influences into the clinical setting and the training of people in those clinical settings, and also not forgetting that policy lever that we can pull to help us move this thing forward. And not to be naive enough as we're working in those policy spaces, because I certainly was. When I started doing nutrition policy, I wasn't trained to do it. I was sort of my, sort of penny loafer epidemiology that got me into those spaces. And it blew me away. People would send me from industry, send me dirty notes at night, calling me all kinds of names and, really trying to thwart these efforts. I wasn't aware of the sort of pushback through their advocacy efforts. And so just being aware and being prepared, and having a more aggressive and expansive and more collaborative approach on our public health side, I think could be really helpful.
Terrific. Thank you so much, Dr. Anderson. We're so grateful to have you leading our School of Public Health. There's one other question. Oh, just a thanks for the excellent and informative talk. Thank you so much again for speaking with us today, and thank you so much for all of your efforts and the inspiring work that you're doing.
Thank you for having me, Dr. Jassel. And again, I appreciate the efforts of the hosts of this Zoom, as well as the Department of Medicine Grand Rounds Coordinating Committee. My pleasure.
I look forward to seeing all of you again next week at Department of Medicine Grand Rounds. Thank you. Have a nice day.